A 26-year-old male presents with mild, dull, chronic back pain. I am showing you his posteroanterior chest radiograph. Describe the findings.
The chest radiograph demonstrates a well-circumscribed, smooth, fusiform mass in the left upper posterior mediastinum, forming obtuse angles with the adjacent lung. The mass has a vertical orientation parallel to the spine. There is smooth spreading and widening of the left fourth and fifth posterior intercostal spaces, with thinning but no osteolytic destruction of the adjacent rib margins. There are also a few focal calcifications within the mass. These findings indicate a posterior mediastinal mass with a neurogenic tumor, specifically a ganglioneuroma arising from the sympathetic chain, being the primary diagnosis.
What is the most common cause of a posterior mediastinal mass, and how are these tumors classified based on cells of origin?
Neurogenic tumors are the most common cause of a posterior mediastinal mass, accounting for approximately 90% of cases. They are classified into three main groups. First, peripheral nerve sheath tumors, which include Schwannomas and Neurofibromas. Second, sympathetic ganglion tumors, which include Ganglioneuromas, Ganglioneuroblastoma, and Neuroblastomas. And third, paraganglionic tumors, such as pheochromocytomas and chemodictomas.
Discuss the significance of rib spreading and erosion associated with these masses, and state the preferred next cross-sectional imaging investigation and the key anatomic feature it must evaluate.
Smooth rib spreading and remodeling are chronic pressure-induced changes typical of benign, slow-growing tumors and do not imply malignancy. However, frank bone destruction is suspicious for a malignant tumor. The preferred next imaging modality is in magnetic resonance imaging of the thoracic spine. Magnetic resonance imaging is critical to evaluate for intraspinal or epidural extension through the neural foramina, creating a dumbbell configuration, which must be identified before surgical planning to avoid spinal cord injury. I would recommend referring the patient to neurosurgery and cardiothoracic surgery.